chapter. Isn't it about time that we had a really easy one? All right. So go ahead and get logged in. Oh, I erased it. Because we do have some questions about halfway through and then at the end. So m.socrative.com, room 42, 33, 42. All right, so let's go ahead and get started. So, shh, y'all got very talkative just now, just right at the beginning of class. You were quiet and you started talking. All right, so we're going to talk about disorders of the eye first, and then we're going to talk about disorders of the ear second. So, similar to some of these other chapters, we use the same diagnostic testing to diagnose the eye, regardless of which particular eye disorder we're looking for or looking at. So all of these, if you've ever gone to the eye doctor, you will have experienced all of these. So the Snellen chart, and there are many similar ones. This is the classic: stand on the line, cover one eye, read the lowest line you can read. There's different versions of this. Like for pre-verbal kids and older adults, there's letters, there's directions. If somebody is nonverbal, you can do the E's. Has anybody ever seen the E's that are in different directions? That's another version. This measures visual acuity at a distance. Now, in a perfect world, you would also measure visual acuity up close, because those two things are different. Just because you can see clearly far away doesn't mean you can see clearly up close. Although most of the time, the Snellen chart is just used from a distance. But there is a reading distance 1, 2 that should be given to assess accommodative vision or close-up vision. A visual field test, typically this is either a machine or a maneuver where you have the patient look forward and then you bring something into their periphery and ask them to make a sound or point or something when they first see it. Normal peripheral vision is right about 170 degrees. So, we can see off to the sides pretty well. We just can't see in a lot of detail off to the sides. Tonometry is everybody's favorite little puff of air into their eye, which most people really do not like, but it's very important because it is the way we measure intraocular pressure. So what we're looking for there is glaucoma, which we're going to talk about here in a little while. But that's what the little puff of air is about. The ophthalmoscope is the fancy name for the device that the doctor or the nurse uses to look into the back of the eye. What we're looking at there is what's called the optic disc, or the part of the retina that we can see looking through the iris in the front. When we dilate patients' eyes, we can see much more of the optic disc, so we can see more of the retina and we can assess its health better. But, obviously dilating people's eyes makes it hard for them to drive home and things like that. So there's other factors there. Gonioscopy is one of these that you probably haven't had done. This is measuring the angle of the anterior chamber. In other words, the cornea-iris angle, which when we talk about glaucoma in a minute, I'll show you that. And then muscle function and coordination. This is just where somebody holds a light or a stick and asks you to hold your head still and you follow the stick with your eyes. And they're looking for the function of your extraocular muscles. Do they go up, down, side to side? And are the eyes coordinated? In other words, are they looking at the same thing, or do you have a diplopia where one eye is looking differently? Yeah.
How did I do that one before?
Which one?
I don't know how to say it.
The gonioscopy?
Yeah, what is that?
That is measuring the angle of the cornea and the iris.
How do they do it?
It's like a camera device. It's a complicated thing.
Okay.
It measures light refraction through that angle. All right. So very common structural defects of the eye are some of the most common genetic illnesses on planet Earth, and that's myopia, hyperopia. That's nearsightedness and farsightedness. Even though they're hugely treatable, they are in fact genetic malformations of the eye. So in myopia, the eye is a little too long, and in hyperopia, the eye is a little too short. In the from the iris to the retina, that distance is a little too short for the lens. And then presbyopia is something that happens to almost everyone with age. And this is the loss of elasticity in the lens. It makes it harder and harder to accommodate. Now, this doesn't mean being nice or being hospitable. This accommodation is, when we look at a distance, our lens is in one shape, but when we look at something at arm's length or at reading length, it requires the lens to change shape. We call that accommodation. So as we get older, our lens gets more and more rigid, and what people will say as they get older is that their arms get too short because they can't hold a thing at comfortable reading level and still see it. So this is the farsightedness that comes along with age. So in myopia, you can see that instead of the eye being perfectly round, it's kind of oval-shaped. It's too long. So without correction, that's in red, the focal point, or the lens, tends to focus light in front of the retina, and that means the light that lands on the retina is out of focus, particularly light that is coming in parallel or from a distance. Now, with correction, myopia is corrected with a biconcave lens like this, so it essentially spreads the light out a little, and then that corrects it, so now the focus lies on the retina where it's supposed to be. In hyperopia, or farsightedness, here it's the opposite problem. Instead of the eye being perfectly round, it's a little too short. So without correction, there again in red, the light rays have a tendency to fall behind the retina. So again, that's going to make a blurry image. This is particularly a problem when items are up close, or when items are up close. So it's corrected by a biconvex lens like this. This is like a magnifying glass lens that narrows that focus and then focuses the light on the retina. So hyperopia and myopia, nearsightedness and farsightedness. Some other structural defects of the eye. Astigmatism is relatively common. Probably some people in here have an astigmatism. This is just where the cornea or lens are not optically perfect. In optics, the shape of the thing means a lot to how the light bends. So in astigmatism, there's an irregular curvature or an irregularity in either the cornea or the lens. And remember that the cornea, this part of the eye right here, the clear part that's in front of the iris, this is where most refraction occurs. So most of the bending of light in the human eye takes place by the cornea. A lot of times people think it's the lens. The lens just does the last little bit. So most of it's the cornea. So astigmatism can occur in either place, either in the cornea or the lens, and it's a refractive irregularity. In strabismus, this either presents as a squint, people close one eye, or as a cross eye, the eyes are not looking in the same direction. And it results from a deviation of either one or both eyes from where they should be. The eye should look in the same direction all the time. The brainstem controls that. So what the patient presents with is diplopia. If the eyes aren't looking at the same thing, you see double. Now this confuses the brain, so people who've had this disorder for a long time have learned to close one eye when they're looking at something carefully, and that blocks out the second image. Now, if this goes on long enough or occurs early enough, that squint actually becomes a neurologic phenomenon. In other words, the patient doesn't squint anymore. In other words, they don't close one eye. Instead, the brain has learned to ignore one eye, and that's what we call amblyopia. And it occurs in children with diplopia who have gone untreated, because when you're a kid, your brain is very flexible. So if the eyes are not bringing in if they're bringing in two images, essentially the brain will just not look at one. It'll ignore one. And if that goes on for too long, it never recovers. The brain never looks at that eye again. So one of the reasons that we fix diplopia is to try to prevent that amblyopia. Now, this can be fixed with refraction, in other words, with glasses. But more and more, it's fixed by fixing the muscles. So surgery is done to correct the alignment of the eye, and sometimes that surgery has to be repeated as the child grows. So that's strabismus. You have to look out for amblyopia. Nystagmus is a sort of lateral deviation of the eye. One of the easiest places to see it in a normal person is somebody who's dizzy. In other words, if you got on a merry-go-round and somebody really flung you around for a while and you stood up, you would see their eyes go like this. It's almost like a typewriter, and that's nystagmus. It results from either an equilibrium problem, a brainstem problem, or a drug toxicity. So any of those things, anything that messes with your sense of balance, our equilibrium senses are sort of wired into our visual system. It's much harder to walk a straight line with your eyes closed. And it's because for us humans, we use our eyes to orient as well as our vestibular system. So when those two things are out of whack, you can get this typewriter-like eye movement called nystagmus. All right, diplopia we kind of already covered. That's just double vision for any cause. So a stroke can result in cranial nerve damage, which means that the extraocular muscles have been deinnervated, so they may not work together anymore. So after a stroke, you may develop a diplopia, an eye that wanders down and to the left, let's say, or up and to the right because of an imbalance between the muscles on the two sides of the eye. Now, anytime you have diplopia, you end up losing your depth perception because the way we perceive how far away a thing is by the difference between the images in the two eyes. So if the images in the two eyes are not focused on the same point, we lose that depth perception. The brain can't make sense out of eyes that are looking in two different directions. The chameleons have us beat on this. They can actually look in two different directions at once, but we can't do that. Our brain cannot handle the misinformation. So either one eye gets paid attention to or the other. It can't make sense out of both. All right. So those are all things you're either born with or develop because of neurologic problems. Some very common infections. Eye infections and eyelid infections are relatively common. Those of us that have kids have probably all seen at least one pink eye by the time our kids are, 6 or 7 years old. And it's because conjunctivitis is one of the most common infections that occur in children. So that's one type of eye infection. The stye, probably some of you in here have had a stye. This is where a hair follicle on the eyelid, so one of your eyelash follicles, gets infected and inflamed. Usually it's from obstruction. Mascara is a big cause of styes because it has a tendency to seal the pore, and then that pore gets infected, it swells up, and you end up with this sort of red knot on your eyelid. They're very painful, very uncomfortable. Usually they're staph infections, and usually they have to be treated with oral antibiotics because it's hard to get, topical antibiotic onto that spot to stay there for a while. So that's a stye. The other is conjunctivitis, we'll talk about in a minute. Trachoma is a particular kind of external eye infection that's caused by the chlamydia bug. And then keratitis is pain and swelling in the cornea, which we'll see in a minute. So conjunctivitis is inflammation of the conjunctiva. Well, the conjunctiva is the lining of the eyelids and the surface of the white part of the eye. So, if you look at the eye from the side, you have an eyeball, right? And then you have the cornea that sort of bulges out there. Well, the cornea doesn't have conjunctiva over it, but the white part of the eye does. So in this area right here, and then lining the eyelid, here's the eyelashes, right? So this is the conjunctiva. So it lines the white part of the eye that you can see, and then the part that you can't see lines the inside of the eyelid. So if anybody's ever had a conjunctivitis, you know that it's sort of itchy and rough feeling. Your eyelids start to feel rough. And it's because that conjunctiva makes a fold and then continues over on the inside of the eyelid. There are lots of different causes for pink eye. We tend to assume that it's Staph aureus, although recent data suggests that there are many more viral pink eyes than we thought there were. But it's simple enough to treat, which is usually what we do for kids and adults with a conjunctivitis. We treat with topical antibiotics, either drops or ointments. The downside with drops is you have to do them like 4 to 5 times a day. Ointments you only have to do twice a day, but it's harder to get it into the eye, particularly in kids. So it's spread by fingers, contaminants, fomites, contaminated towels, makeup, things like that. Contact lens wearers are at increased risk for conjunctivitis because contacts can grow bacteria. The solutions that we use to take care of our contacts are antimicrobial, and the reason for that is to prevent conjunctivitis. I've got some pictures of bacteria in contacts here in a minute. Some other causes, particularly nasty conjunctivitis, chlamydia, the chlamydia bug, and the gonorrhea bug can both cause a conjunctivitis. Now this it usually affects newborns because the exposure is through the reproductive tract. One of the reasons why all women as part of their prenatal care are tested for these STDs is to try to prevent the bad conjunctivitis that can result from newborn eye exposure to these bugs in the GU tract, in the birth canal. But even adults can get chlamydia or gonorrhea conjunctivitis from self-inoculation, classic hand to eye. All right, so this is a gonococcal conjunctivitis. You can tell that that's a lot worse than your typical pink eye, right? There's exudate here, there's sort of this cloudy fluid there. And this is what makes gonococcal conjunctivitis so bad, is it has a tendency to be purulent like this, where you get this white pus, and it will fibrose, and it can cause blindness.
I was going to ask you if it created scar tissue.
Yes, it scars the conjunctiva, can cause blindness. Now, thankfully, in conjunctivitis, usually the cornea is spared because there's no conjunctiva there, so you can see that the redness doesn't continue up. And it's because now we're into that special part of the eye that's crystal clear and doesn't have any vessels. So the scarring would be to the sclera and to the conjunctiva, which is here. But it can result in like people who can't open their eyes all the way because the conjunctiva has sort of matted down and scarred. We don't see this really in this country, but in developing countries we see major problems, even blindness, from some of these very preventable conjunctivitis infections. So here is a contact lens taken out of a person's eye and put on a bacterial growth plate, and you can see that you get this nice, beautiful ring of bacteria around these. So contact lenses do harbor bacteria. There's lots of different kinds. The most common there are the Pseudomonas, which is a particularly nasty bug, but it likes really wet places, so it kind of makes sense that it would be that one. But Klebsiella, Staph aureus, here's one that I've never heard of, Serratia, which some of you from micro would be able to tell me things about. But all that to say, contact lenses are safe, but you do have to take care of them. They do need to be sterilized. The recommendation is every night. Patients who sleep in their contact lenses have an increased risk of conjunctivitis because the bacteria isn't getting killed every night. All right. So trachoma is caused also by chlamydia, and this is where the inside surface of the eyelids end up getting these follicle-like lesions in them. It creates a scratchy eye. Treatment is with antibiotics, and your book points out that this is one of the most common causes of vision loss where water is scarce and there is inadequate hygiene. So this is, you could call this a chlamydial conjunctivitis, yeah.
How do you know, or for like, is there like lab tests for eyes? Will they take like a swab to decide?
You can culture an eye, yep.
Okay, so
yep.
Usually if you go in, you have an eye problem, it's, okay, I shouldn't say usually, but like.
In this country, they are not going to culture your eye.
Yeah, I don't think they were
No.
going to chlamydia in my eye. I think they
No.
just thought it was,
And they look different. The gonorrhea and chlamydial conjunctivitises are much worse. So if you see a nasty purulent eye, yeah, you might culture it and send it for those. All right. Keratitis is usually caused by the herpes simplex virus. This is the same virus that causes the cold sores, herpes cold sores. This is the type 1. And it can be transferred from one mucous membrane to the next. The conjunctiva is a mucous membrane. So if you've ever had a cold sore, if you can imagine having a cold sore in your eye, you can, imagine that that's going to be pretty painful. So there's ulceration. Now this one can erode the cornea because of the proximity to it and can lead to scar tissue. Anything that scars the cornea can result in vision loss. So whether that's infection, trauma, anything that affects this region of the eye right here is of big concern because of it doesn't. If it doesn't grow back clear, you're going to have vision loss. All right. So before we get into glaucoma, we have to review the normal. Okay, so we're looking at part of the eye, like right here. Here's the cornea, here's the sclera, and we're looking at it from the side. So what you're seeing here, this is the iris. So this is the colored part of the eye that changes size. In between the circle of the iris is the pupil. The lens sits just behind the iris. And then behind it is what's called the ciliary body, which has a muscle in it that tugs on the lens to create accommodation. But it also is the site where aqueous humor is formed. Behind this, so all this area back here, so like from here back, that's the posterior chamber of the eye, and it has the vitreous humor in it, which is sort of a clear gelatin-like stuff. It's not fluid, it sort of is jello-like. So glaucoma is all about the anterior chamber. So in front of that vitreous humor here, so from the lens on up, that's the site where glaucoma does its thing. Now, aqueous humor is constantly being made and reabsorbed. So it's made here by the ciliary body. It flows between the lens and the iris and into the area behind the cornea, so like right here. So the area behind the cornea is filled with aqueous humor. And then it's reabsorbed at the corner here. See where the iris meets the sclera? It makes a kind of angle right there. Well, that's the site of reabsorption of that aqueous humor, and that takes place in the canal of Schlemm, which is a great name. Canal of Schlemm is where aqueous humor is reabsorbed. So this is normal. So when they puff that little puff of air, what they're measuring is, that puff sort of rebounds off the cornea and pushes back. The cornea pushes back, and they measure your intraocular pressure, which is the pressure in your anterior chamber. Okay? Usually that's about 10 to 20 millimeters of mercury. So glaucoma is an increase in that intraocular pressure. And it results from too much aqueous humor. And there's two paths to get there. But you end up with increasing aqueous humor in this area. The pressure goes up. And what happens is that pressure literally pushes everything back. And because the vitreous humor in the posterior chamber doesn't compress, if you push things from the front, in the back is the retina, and the retina ends up getting pushed or squeezed. So left untreated, glaucoma can result in blindness because the retina becomes ischemic as it gets squeezed up against the back of the eye. So glaucoma is a potential cause of blindness, and your book points out it's one of the most common causes of preventable blindness in the developed world. Yeah?
So does that squeezing alter, the light refraction too? So it doesn't cause
No. That's one of the problems with glaucoma is it doesn't produce symptoms early enough for us to catch it.
If it was squeezing or changing the shape by squeezing, then the light would be
Yeah, it doesn't cause any vision changes. And it's because the eye is, hard. The outer covering is rigid so it doesn't stretch. So essentially that pressure is all transferred to the soft retina at the back. Yeah. All right, so that's the normal. So glaucoma is an increase in intraocular pressure, common cause of blindness. Signs and symptoms, halos around halos around light at night. And this is because of a deformation of the lens, so a little bit of visual change. Loss of peripheral vision as that pressure squeezes the retina. And then pain, but only if the intraocular pressure is hugely increased and acute. It has to happen right away. So there's two paths to this. There's a sudden onset, and we call that closed angle glaucoma. and then there's an insidious onset, or open-angle glaucoma. So in the acute, or narrow-angle version, what's happened here is the angle between the iris and the sclera has gotten very narrow. You know, this angle right here, this is supposed to be much more open. When this starts to squeeze like this, the aqueous humor can't get to the canal of Schlemm to be reabsorbed. So it's being made, but it has nowhere to go. So it ends up building up pressure in this anterior chamber and starting that process of pushing everything backwards. So this can happen because of aging, as the lens becomes less flexible, developmental abnormalities, so this can be something you're born with, but doesn't necessarily trigger symptoms very early. So anything that pushes that iris forward and to the side is going to block the outflow of aqueous humor. This can also be triggered by pupil dilation. So in some cases, you know, you go to the eye doctor, and for the first time you have your pupils dilated. That can actually trigger your first attack of closed-angle glaucoma. Because as your iris dilates, it gets thicker right here as the muscle relaxes and gets pulled open, and that thickening can actually block that narrow angle, or that closed angle. The treatment here is sometimes medical. You keep the pupils constricted, and that tends to open them up. But ultimately, it may involve surgery to fix that angle, either to change the angle of the iris or to free up some tissue here so that the aqueous humor can get where it needs to go. So that's the acute version. In the chronic, or open-angle glaucoma, this has a higher incidence in people age 50 and greater. And this is not a blockage, it's a breakdown. So the canal of Schlemm, what feeds into it is called the trabecular network. And if that trabecular network starts to thicken, as a lot of things do with age, you know, it loses its precision and starts to thicken, essentially the uptake spot, that canal of Schlemm, the aqueous humor can't get to it. So not because the iris is in the way, but because that trabecular meshwork, or trabecular network, is blocked. So the reason this happens slowly over time is this doesn't happen all at once. It's slowly over time, this trabecular network starts to clog up, so to speak. So at first, the absorption is just a little reduced, and then it gets a little worse, and then a little worse, and then before long, you have very high intraocular pressure because the aqueous humor is being produced faster than it can be reabsorbed. So this can be treated, again, with eye drops. Helps to open up that angle and increase the reabsorption. This one is particularly dangerous because it's a slow, steady increase over time, so it may not cause many symptoms, but eventually you get ischemia and damage to the retina. Eventually the optic nerve can be affected as the vitreous humor is literally pushed towards the back of the eye. The optic nerve gets pushed out of the eye and starts to get impinged. So it's irreversible, and eventually this can cause blindness. So it's one of those things, patients may be treated with eye drops for long periods of time to try to prevent that from occurring. All right. Another disorder associated with aging, again, exceedingly common, particularly as our population continues to get older. But cataracts. Cataracts are clouding of the lens. So you've got the cornea in the front, then you've got the iris, it looks like this, and then behind that you have the lens. Now the lens is almost rubbery in the living person, so it's it's dense and clear, and over time some people develop cloudiness on the inside of this lens. And it's progressive, so it starts with just a little cloudiness, and it progresses until at some point light is being so scattered by the cloudiness that you start to get problems with visual acuity and approaching blindness. Interestingly, it can occur in the different eyes at different rates. Like you can have a cataract in one eye and not the other. You can have an advanced cataract in one eye and a mild one in the other. We don't really know exactly what causes this. Certainly it's age-related. There are some metabolic abnormalities that accelerate cataract growth. Excessive exposure to sunlight. So one of the reasons we encourage people to wear sunglasses or have UV coating on their eyeglasses or contacts is because it's supposed to reduce the incidence of cataracts. And then it's can be congenital or traumatic. So when you look in a person's eyes with cataracts, you see this sort of blue hue on the inside. You know, normally we would see red, right? The red reflex or the red eye. In the patient with cataracts, we get this kind of blue cloudiness to it. Now, this patient has had their eyes are dilated, so you can see how big the pupil is. But the lens in the middle is cloudy. All right. And like you'd expect, you know, a cloudy lens is going to make for cloudy vision, right? So you get blurry vision. It gets darker with time. Night driving is one of the first places where older patients have symptoms of cataracts, and it's because that cloudiness is scattering the light as they drive. And you know, when we drive at night, it's mostly black with white or black with light foreground. So it's night driving becomes particularly difficult. All right. When it starts to interfere with a patient's ability to work or see, then it's time for surgery. Now, amazingly, I think cataract surgery is outpatient, and they go in and they take the old opaque lens out, and they take a new lens that's been created in the lab, and they put it in. So literally, it's a lens replacement. The old one comes out, the new one goes in. And what's interesting is, let's say you are myopic. You know, you've been nearsighted your whole life. The lens they put in can fix that for you because it's like putting an eyeglass on the inside. So very often after patients have had cataract surgery, if they've worn glasses their whole life, they may not need them anymore because the new way this surgery is done, they make your vision perfect as part of it. So
why don't they use that for vision correction?
Because the downside is this lens doesn't change shape. So patients with cataracts will always need glasses for up close or far away, depending on their choice.
That can be a side effect of LASIK too, though.
Oh, really? I hadn't heard that. The other reason is LASIK takes place here at the front of the eye, so you don't. It's more invasive. Yeah, replacing the lens is more invasive. But patients do very well with cataract surgery. Even your very old, very fragile patients do very well with cataract surgery.
Doing that and the drop regimen is like ridiculous. Like these 3 drops this 5 minutes, and then these 7 drops the next minute. Then this ointment, I'm like, oh my gosh, this is just dramatic.
Yes, but that doesn't go on for very long. Okay, so moving from the front of the eye to the back of the eye, a detached retina is just what it sounds like. Essentially, the retina, which is really relatively loosely attached to the back of the eye. So here's the retina attached to the optic nerve. In detached retina, part of it or all of it basically comes off, and it just kind of sits on the inside of the eye. Now, the problem with this is the retina has its own blood supply, and when it detaches, it loses that blood supply. So it's a medical emergency because of the ischemia that can result. If you can reattach that retina in a hurry, the retina will survive. If you can't, that retina is going to die from a lack of oxygen, lack of blood flow. Believe it or not, there's no pain or discomfort with retinal detachment. The only symptom is that quite suddenly the visual field changes. So you begin to have areas of blackness because, part of the retina is not functioning, it's detached. So those are called scotomas, or areas of blackness in the visual field. The common description that you hear is it's like a curtain has fallen over part of the visual field. So detached retina. Once it detaches, the vitreous humor has a tendency to finish the job. It pushes in and separates the rest of the retina out and can cause further damage from that. So the treatment here is surgery. What they do now is they go in and they put the retina back in place, and they use a laser to kind of spot rivet it in several spots so that it can't detach again. So it's a laser-based surgery. They make little scars in a few places, but those scars work to hold the retina in place on the back of the eye. All right. Now this one's bad, macular degeneration. The most common cause is age-related, so it's called AMD. Common cause of visual loss in older adults. We don't really know what causes it, but there's genetic factors and environmental factors. There's two forms, but the short version is the macula is the site of the eye where we have our color vision and our detail vision. You know, so we're able to see very crisply, particularly in a well-lit room, because the macula has huge numbers of cone receptors that are all packed into a very small space. Well, in macular degeneration, that macular area degenerates, so it starts to fall apart. So where a person's vision was like this, with macular degeneration, you get this. So you notice that it's the center and detail areas that are lost. But around that macular area, we still have some vision, albeit blurry. So one of the things that these patients do is they have a tendency to look at things not straight on like we're used to, but they look at things out of the side of their eyes. So they'll turn their head to look at you and look straight, but they're looking at you mentally. And that's because they're avoiding that degenerated spot there. So with macular degeneration, there's no treatment as of now, but there are new therapies being investigated. Because can you imagine that would be a terrible thing to have, to no longer be able to see the details in the middle of your life, so to speak. Yeah.
Does light have anything to do with that at all? Like dark versus light, like seeing in the day versus the night?
No. I mean, your macula is most active in bright light. So like in macular degeneration, you would still have a hole, but your night vision would be better on the periphery, because our night vision is better out here, and our color vision is better in the center. But yeah, it's a degeneration of both the rods and cones in the macula.
Are
So
there
yeah, it's a bad
other
one.
things that are similar to that?
Not that I know of. Yeah, this one's particularly bad. Okay, so has everybody answered the question, the student number question?
Exactly.
I have 11, but only 9 answers. So jump in there and answer that question for me. What, Carolyn?
This is retarded. It'll work by the time you ask the third question.
All right, there we go. There, now I have 11 answers. Very good. Okay, so which of the following involves gradual clouding of the lens of the eye? Is it just slow?
Yeah, because I got it when there was like 2 seconds left, and I got it.
All right, there's 11. So yes, that's a cataract. Glaucoma is all about intraocular pressure. So the anterior, because somebody put that one, the anterior chamber, there's an imbalance between aqueous humor formation and reabsorption, so you end up increasing pressure, which pushes back on the retina. All right. Which is the basic pathophysiologic change with macular degeneration?
Complicated terms. I have this problem, but only at night. I know my doctor can't explain to me.
What, that you can't see well in the center of your vision?
In one eye, there's a giant gray spot, but it's only at night. And I can see around it, but the gray spot is like weird. It looks just like that picture, only it's only at night.
And you've been checked out, right? Okay, good.
Maybe I think it's in my head.
No, it sounds like you've had a rod degeneration in your macula.
I mean, that's what he attributed to it. He just doesn't know why. He said there's no way of proving it.
Huh.
Disproving it.
Well, yeah, you can't look that close.
He said it's impossible to look. It's not impossible, but he said he just doesn't know how he would test for that.
Yeah, they'd have to do like a biopsy of your macula. You would not want that because
losing more.
Yeah, you'd be losing more. That's interesting.
Maybe. I'm gonna name it after.
Okay, so that is C, degeneration of the retinal cells in the fovea. Okay, so that's a new phrase, right? If here's the retina, right, the area of best vision is called the macula. And in the center of the macula is called the fovea. So the fovea is the focal point of the eye. So light that comes into the eye, it's focused, boom, right on the fovea. So the fovea is the area of best, most detailed color vision. Surrounding that is the macula, which is the area of best vision, or you know, basically fovea is like an extreme version of the macula. And then all around here, this is just optic disc. So most of this area is rods. Your cones are all in the macula, and the highest density of cones is in the fovea, also called the fovea centralis. So the degeneration of retinal cells around the fovea, well, that's going to be the macula, so that's macular degeneration.
And it's just above the optic nerve.
The optic nerve is over here.
Oh, it's just,
Yeah, it's to the side. Yeah. Okay, which fluid is constantly secreted and reabsorbed? Yeah, we evolved to have our optic disc, because this is a blind spot where your optic nerve exits the eye. So it's in a spot we don't notice very much. You can find it, you know, you can close your eyes, look in one direction, move your thumb out, and your thumb disappears. Have you ever done that?
No.
Yeah, you can find your optic nerve. You have to close one eye and look straight ahead. Start looking at your thumb, right? But don't follow your thumb. Continue to look ahead, and at some point your thumb will disappear. And that's your blind spot.
It's in my hand, but I can't see my thumb.
It's like, for me, it's right there.
I don't think that's working.
Don't follow your thumb. Keep looking straight ahead, but move your thumb, and then eventually it'll disappear.
I can still see it.
It's right there. It's gone. No, it's gone. I can't see it.
Yeah, there's a true blind spot in everybody. Now, the interesting, why don't we notice it? Well, we have two eyes open all the time, right? So they cover each other. You know, what's blind in one eye is covered in the other eye, so it doesn't come up.
What about when you've got that little white cloud that kind of moves around?
A floater?
Yeah.
Is that what you're talking about? That's usually something floating around in the aqueous humor or vitreous humor. Yeah. All right, good. That's the aqueous humor. Aqueous humor. I can't believe y'all have never done your blind spot thing. That should be done in every high school health class. All right, so from eyes to ears. Okay, so hearing loss. Obviously, one of the most concerning things that or the thing we're concerned most about the hearing system or the ear is deafness. So there's two types. There's conduction deafness and there's sensory neural deafness. So in conduction deafness, there's something preventing sound waves from being conducted into the sensory part of the ear. You know, the cochlea is our organ of hearing. But in order for the cochlea to work, sound waves have to be transduced a couple of times. You know, first, the sound has to move your tympanic membrane. The tympanic membrane has to move your ear bones, your ossicles. As the ear bones move, the ossicles move against the oval window, and that is what transmits sound into the cochlea so we can actually hear it. So in conduction deafness, there's some problem with that transduction of sound from the air into the cochlear organ. So it can be as simple as a blocked external ear or middle ear, you know, a case of a bad ear infection, or you know, an ear that's full of earwax, or a foreign object, which in peds you see foreign objects in ears. or a disease called otosclerosis. In otosclerosis, the ear bones essentially get bound together and they get too big, so they don't move as well, and it reduces the amount of sound energy that's transmitted into the cochlea. The sensory neural impairment is sort of a problem on the inside. This is where that organ of Corti that's found in the cochlea is damaged, or the auditory nerve is damaged. So this can be an inner ear infection, head trauma, neurologic disorders. There are a number of ototoxic drugs like gentamicin, for example, in overdose destroys the organ of Corti. Sudden, very loud sounds, or being outside of a jet engine, let's say, without hearing protection, or prolonged exposure to loud noises also cause sensory neural impairment. So these are people who work around very loud sounds, or who are into loud hobbies, like firearms or concerts, things like that. Over time, that loud noise can actually affect your organ of Corti and make it less and less sensitive. All right. In newborns, hearing is important because studies have shown and research has shown that if we can improve a child's hearing early on, they do much better than if the hearing loss isn't found out until later. So in America now, we screen all newborns for hearing. We do a newborn hearing test on everybody, and if it's abnormal in any way, then we get an audiologist or an otolaryngologist involved. Because we have options, Hearing aids are the old school way. Basically, they amplify sound, and they amplify sound in certain frequency ranges to help people understand others better. And now we have this fancy device called the Cochlear Implant, which actually stimulates the organ of Corti directly. It looks sort of like this. Inside the skull, excuse me, there's a receiver/stimulator that's wired up to the cochlear organ here. And then on the outside, they're usually connected with a magnet. There's an external transmitter with a microphone, a battery pack, and a little computer inside. And essentially, it becomes a sort of bionic ear or a prosthetic cochlea. Now, this doesn't work for adults, because what is created by the cochlear implant is not exactly what the cochlea would make normally. But for children, if you put this in early enough, they can use it just like it's their own cochlea. And that's because their brains are so much more flexible than adults are. So one of the reasons that we screen newborns for hearing problems is because we have this new advanced technology that can actually prevent deafness, certain kinds of deafness anyway, by directly stimulating the organ of Corti. Yeah.
So if a little kid has this put in, will it work for their adult? Or do they hit an age?
Nope, it'll work forever for them. The problem with the adult is they've already learned what hearing is and what sounds are supposed to sound like. The kids haven't learned all that stuff yet. So now adults can have these, but it doesn't work nearly as well as it does with kids.
There's no way to retrain your brain. I know they're always calibrated and stuff like that, but there's no way to...
You can, and adults do get them, but it's never as successful. It's just like vision. If you're congenitally blind, even if we found a prosthetic eye that worked, you probably would never see like other people do because you just never learned to. Your brain never picked it up. So once you've learned one thing, particularly in perception, like sound, sight, smell, it's hard to replace that with something else. But, yeah.
So this comes off though, right? Like you can take it off?
The outer part you can, but the inner part doesn't. It stays in there.
Yeah, but I mean, so you could, like, in a sense, turn it off.
Yeah, you can take it off to shower. You have to take it off at night to charge it, and stuff like that. But it's we're on our way to the Borg. Any of those people who know Star Trek, so we have actual neurologic implants that can help people hear, which is kind of cool.
Now I just see those cool glasses and all the
So just a little vocabulary. These three things are not the same. So deaf, deafened, and hearing impaired are different. So deaf technically means congenitally deaf. Deafened is that they acquired a hearing deficit, and then we don't use hard of hearing anymore. We use hearing impaired instead. So most of those things are, at least the hearing impaired ones, are usually taken care of with hearing aids. So some other ear things. Otitis media is, do I have a picture? I do not have a picture. This is an infection in the middle ear, so between the tympanic membrane and the round and oval windows. This is where your auditory ossicles are, your ear bones are in there. And essentially the pathophysiology here is that space fills up with fluid, usually from an upper respiratory tract infection. That fluid becomes infected, and now you have an otitis media. So it's an infection of fluid in that space behind the tympanic membrane. Repeated or prolonged infection can cause scarring of the tympanic membrane and can result in a conductive hearing loss. When that TM gets too thick, it doesn't vibrate as easily. So that's one of the reasons we're vigorous in treating ear infections in kids. And then left untreated, an ear infection can actually lead to a much larger infection called a mastoiditis, and that involves the bones just underneath the ear, which can even lead into a meningitis. So ear infections usually spread along the nasopharynx. You know, the eustachian tube connects the middle ear to the back of the throat, so stuff can go backwards. You know, a strep infection can work its way up into the middle ear. One of the most common causes of ear infections used to be Haemophilus influenza, which is a bacteria, not a virus, even though it's called influenza. But now there's a vaccine for HIV, so we don't see that as often. Same with strep. So the ear infection epidemiology is changing, you know, because now kids get a streptococcal vaccine, they get a HIV vaccine. So the organisms that cause ear infections are systematically being, you know, eliminated. So we're seeing more viral infections. There's even a movement in pediatrics to not treat ear infections like we used to just let them go and or to lance the tympanic membrane. In other words, put a little hole in it to allow that effectively that abscess to drain. So things are changing about ear infections. But yeah.
Isn't the reason they're not treated anymore is because of the overuse of that?
Yes, resistance. Yes, yep, resistance.
Or are they trying to not use tubes anymore?
Nope, tubes are still a good idea. In fact, they're quicker to put tubes in now than they used to, because once you have tubes, it's harder to get an ear infection because you can't fill it up with fluid. Yeah.
So you said that they'll like lice the eardrum to try and like get some drainage. Do they then not?
It's called a tympanotomy.
Do they not put a tube in at that point? So I thought the eardrum healed really rapidly.
It does. Couple days, but that's long enough to drain the abscess. You know, essentially a middle ear infection is an abscess because it's a walled off area of infection. So what a lot of pediatricians are doing now is called a tympanotomy. So in the office, you take a sharp instrument and you just pop a hole in a safe part of the tympanic membrane. It drains, and then the infection gets better. Just like popping a zit, so to speak. Yeah. Okay. So in that case, like here's what we look at when we look in the ear and we see the tympanic membrane. Here's nice, shiny, normal tympanic membrane, right? It's bowed out a little towards you. So like if we were going to pop a hole in this, we would do it here or here because there's nothing behind those two spots. That's another reason to do a tympanotomy or break the membrane is you get to choose where you're going to break it. If it breaks on its own, it can break anywhere and can cause further problems. Yeah.
What do they do about like pain?
You can numb it. You just spray a little lidocaine in there and then pop it. It's quick. I mean, and the kids their ears already hurt, so in some ways it doesn't hurt as much as you might think.
Could it be instant relief?
Yeah, or adults say that it's instant relief. You know, little kids you can't tell, but so this is a same view. You know, this is otitis media. So what are we looking at? The tympanic membrane is bright red because it's inflamed. It's got infection behind it. You can see, doesn't show up very good, but this yellow stuff, this is pus in the middle ear. So we're looking through the tympanic membrane and we're seeing, purulent exudate on the other side. So this is a classic, otitis media presentation. Otitis externa, that's swimmer's ear. This is an external ear infection, so really it's an infection of the auditory canal. We call it swimmer's ear because a lot of swimmers get it, and the reason for that is the chlorine has a tendency to disrupt the chemistry in the ear canal, causes irritation, and then that irritation can end up getting secondarily infected. So pretty straightforward, otitis externa. Some chronic disorders. Otosclerosis is a leading cause of progressive conductive hearing loss. So many of your elderly patients who have hearing aids, this is why they have hearing aids. It's otosclerosis. And this is where, over time, the ossicles have gotten thicker and heavier and less flexible with respect to one another. So as that happens, the stapes, which is what connects to the oval window, and the oval window is the entry to the cochlea where hearing actually happens. Instead of being able to move against that, it gets locked to it. So now if it can't move, it can't send sound energy into the cochlea, so the hearing deficit develops. So there's both genetic and environmental factors here. There is surgery for this. An otolaryngologist could actually go in, remove the stapes, and put a fake stapes in, and restore a great deal of hearing. So there's a little upside to the conductive hearing loss. Meniere's syndrome is sort of a weird one. It's an infection of the vestibular part of the ear. You know, the labyrinth of the ear is where the semicircular canals are, and the utricle and the saccule, it gives us our sense of equilibrium and motion. Well, in Meniere's disease, there is a excessive production of endolymph. Endolymph is the fluid that's found inside these ear parts, so the semicircular canals, the vestibular organ, all full of endolymph. And this Meniere syndrome, it has remissions and exacerbations. So, and it can, the triggers can vary. But essentially, it's a sudden onset of disequilibrium. So dizziness, feeling like the room is spinning. Oftentimes, these patients can't keep their balance when they're in a Meniere's attack. And the attack can last for minutes, hours, or even days. So patients who are diagnosed with this by these tests, balance tests, MRI, and then basically looking at the labyrinth with a variety of different treatments, there are some medications that work for people. And also there's some, you can train your brain and vestibular apparatus to not be so sensitive to motion too. So Meniere's disease is a weird one because it affects the vestibular system but not the hearing system. All right, so let's do a few more questions and call it a night. In a case of acute otitis media, what would a purulent discharge in the ear canal, whoops, wrong kind of question, hold on, likely indicate? I sent you a true or false question, ignore that. There. Okay, there we go, multiple choice. All right, good. Most of you got that. That's going to say that it's ruptured. You know, the middle ear, you know, effectively you've got a confined space. So you've got your TM on one side, you have kind of a roof, and then you have your you have bone over here. So an otitis media fills this up with pus, and if the pressure is high enough, it will actually pop a hole through the tympanic membrane, and you'll get pus in the ear canal. Now, for adults and for older kids, they'll say that, oh, my ear finally feels better as this nasty green smelly stuff is oozing out of their ear. And that's because finally the pressure has released. And usually once this happens, most ear infections clear up on their own. So once you get that nasty stuff out, the body's own immune system can clear it up pretty well. All right. Which of the following is often the first sign of ototoxicity from drugs or chemicals, which is something we didn't talk about, but it's a good lesson anyway. So think critically here.
Can you pop your own membrane with like a Q-tip? Or is it part of that?
You can. You'd have to be really going at it, though.
Well, so it's just
And you would stop with the Q-tip before you popped your membrane, because the further you go into the ear canal, the more sensitive it becomes. So you would stop before you did it, because like when you do a tympanotomy, the whole trick is you don't touch the sides of the ear canal. You hold the kid's ear up and you just go straight in and you don't touch the sides, because the tympanic membrane isn't very sensitive, but the ear canal is.
so like when your ear feels like it's draining, when
Mhm.
you like go on the Q-tip and it's kind of runny-ish.
You might have a little hole in your membrane, yeah. It might have popped open. Oh, okay, that's everybody. That's tinnitus. And I know we didn't talk about that. Tinnitus is ringing in the ears, right? And ototoxicity is an effect of medication on the sensory neural part of the ear. So of those things, what would you likely see? Severe pain? No, the cochlea is not going to create pain if it's dying or getting sick. Sudden total loss of hearing? Doubtful. Fluid exudate draining from the ear, that's either an external ear infection or a ruptured middle ear. So the only one that's left is tinnitus. And you'll learn in your pharmacology class that there are a number of medications that we routinely use that are ototoxic in overdose. Particularly the one that always comes to mind for me is gentamicin. If your gentamicin levels get too high, you kill the ears, and the first response that the patients have is tinnitus, as that ringing in the ears as the organ of Cont'd is being affected. All right, let's call it there, folks. Nice, easy, straight.